I'm going to talk about antidepressant withdrawal effects and safety prescribing. I had to update my talk this afternoon because I'd seen that the new CANMAT guidelines had been put out that addresses this issue in part. So I'll speak to that slightly. So I'll start with a case study. A woman in her 50s turns up to a medical appointment saying that she is feeling anxious, can't sleep, and is having panic attacks. She stopped 100 milligrams of sertraline 3 weeks ago because she wanted to try going without it because it was making her feel flat and groggy. She was given antidepressants a few years ago from the death of her mother. She was then lethargic and depressed and slept long hours. She's felt a lot better the last couple of years, but feels like she's numbed on medication, has put on weight, and feels tired during the day. And she began to wonder if it was the medication. Her symptoms came on about 2 weeks after stopping her tablet. She's now not sleeping and anxious, and it has gotten worse the last few days. She also feels dizzy, slightly unsteady on her feet, and like things around her are dreamlike. So no points for the diagnosis in a lecture called Antidepressant Withdrawal Effects. This is an example of antidepressant withdrawal syndrome. There are a few aspects that are worth noting. The onset was 2 weeks after stopping. Textbooks often say it comes on within a few half-lives of stopping a drug. Sertraline has a half-life of about 20 hours, but you can see delayed onset of weeks and sometimes longer, maybe because it takes longer to dissociate from the central compartment. There's some neuroimaging showing that dissociation from the SERT transporter can take longer. The presence of physical symptoms that she had, dizziness, unsteadiness on her feet, and that dreamlike sensation often called derealization is not present in anxiety and depression and helps to differentiate it from a relapse. And even more so, if you recall, when she was depressed at first, she was lethargic, depressed, slept long hours. Now on withdrawal, she's not sleeping, anxious. So these are different symptoms. That is a way to distinguish from the original condition. Some doctors will conclude this woman has developed a new onset anxiety or panic disorder, but that is much more unlikely that she would have a new disorder that would come on just at the point she stopped medication, rather than having quite common withdrawal symptoms. So I think in terms of the likelihood, it's much more likely to be withdrawal. And the other issue, which is true of lots of people on antidepressants, is they're prescribed medication at a stressful point in their life, often following divorce, grief, job loss. Most of these people do not have recurring conditions. You cannot have a relapse of divorce for most people. We'll talk more about what would be a better way to stop medication later in the talk. I wanted to give you another case study. This is of a woman that I've seen in the last couple of weeks. This is a more extreme version. I think this is a sort of case that's often missed by doctors, and therefore people don't appreciate how severe coming off these drugs can be. A 30-year-old woman on the same medication, put on it at age 19, when stressed at university. She came off over 4 weeks under her doctor's instruction, halving the dose to 50 milligrams for 2 weeks, and then taking 50 milligrams every second day for 2 weeks and then stopping it. On stopping, she developed panic attacks. She began pacing backwards and forwards in her room. She was restless. She felt brain zaps in her head, this kind of sensation of electric shocks in her head. She felt emotionally numb. She lost sexual function. She had an altered sensation on the right side of her body, an altered sense of heat and cold. She had spasms of her muscles in her leg and abdomen, and she had bladder pain, and she became profoundly suicidal. Just at age 19, when she'd gone on the medication, she was doing a degree in marketing at a good university in England, and her major issue had been stress before exams. So none of these symptoms had ever occurred to her in her life before this, and she was working in marketing and otherwise a high-functioning young woman. She tried to restart her sertraline in order to manage these withdrawal symptoms. She put it off for several weeks because she became afraid about going back on this drug that had caused her all these troubles when coming off of it. When she restarted the drug, her symptoms worsened and she stopped the drug after a few days. She's now 3 months from when she stopped, and she has had no improvement in her symptoms. She paces each day and she's highly suicidal. Her parents became understandably concerned about her, took her to the emergency department. She was admitted to an inpatient ward. The treating team told her that it was not possible that her symptoms were caused by sertraline, as the drug was out of her body, and withdrawal symptoms were mostly mild and brief. They diagnosed her with a psychotic disorder and decided to restrain and medicate her with an antipsychotic because she was refusing medication. The evidence of her having a psychotic disorder was what they perceived as a delusion that medication could cause her harm. Her parents are very unhappy with the treatment that's occurred, and it will probably lead to a lawsuit. Every symptom, by the way, before we get to it, that she's mentioned here is recognized in protracted withdrawal effects from antidepressants in several academic articles. So where has this all come from? I'm very much focused on the UK. I've tried to add in what Canada has said. They're very similar stories. In the NICE guidance in England up until 2019, the guidelines said that discontinuation symptoms are usually mild and self-limiting over about 1 week, can be severe if the drugs are stopped abruptly. The CAN-MAT guidelines, which were updated a couple of days ago, say much the same, mild to moderate in severity and resolve within a few weeks. The description in both of these guidelines was influenced by papers published by the drug manufacturers in the 1990s and 2000s. And these papers focused exclusively on people who had been on antidepressants for 8 to 12 weeks, with a single study for 24 weeks. And when these people stopped their antidepressants, they mostly did have mild and brief symptoms. That is true. A minority had quite severe symptoms when stopping, but most people had mild and brief symptoms. As we'll see, the longer you're on a medication like an antidepressant, the harder it is to stop and the more severe the symptoms become. So to me, this is a little bit akin to a car company crashing a car at 5 kilometers an hour into a wall and saying the car is safe and ignoring the fact that people are driving around at 60 kilometers an hour because they're focusing on very short-term use. The term discontinuation symptoms was coined by the manufacturers in order to minimize concerns around addiction and to have their product not associated with things like benzodiazepines. And they distributed numerous papers about this that described withdrawal as brief and mild. And that is what has entered the literature and been imported into guidelines like NICE and the CAN-MAT guidelines. On how to stop antidepressants, previous NICE guidance said gradually reduce the dose over a 4-week period. Some people may need longer periods, but with no detail given. CAN-MAT says something similar. They've added the word months in their update. So it's been, I think, 8 years since the last update. They've added in the phrase all months. They recommend against using liquids or compounded meds. They talk about maybe spacing out the reductions at greater intervals. We'll look at that, how that plays out in people's for people. There was a freedom of information request made to the NICE guidelines, and what it found was the guidelines had been based on expert consensus. There was a single study showing that when drugs were stopped abruptly, that withdrawal effects were too severe, and the committee decided that 4 weeks would be a reasonable time. There are randomized controlled trials showing that there's no difference in withdrawal effects whether you stop in 2 weeks, 4 weeks, or abruptly. This has become common practice. Most doctors will recommend halving the dose for 2 to 4 weeks and then halving it again for another 2 to 4 weeks. A randomized controlled trial in Holland tested just this approach, this halving and then halving again, and found that just 1 in 16 patients were able to stop their medications. This is for a group of people who are on their drugs for more than 12 months. This might be an underestimate of how effective this treatment is because some of those patients refused to start coming off, although they were all deemed to be on medication for longer than they were needed to be. In other words, this technique of stopping in a few weeks has been shown to be ineffective for the vast majority of people on long-term antidepressants. The consequence of the mismatch between what guidelines recommend and what patients experience has led to an explosion of people exiting mainstream healthcare to seek advice on how to come off antidepressants from online websites. And 2 of the most popular websites are Surviving Antidepressants and the Withdrawal Project. Actually, these are outdated figures. Between the 2 of them, they now get more than 1 million hits a month. I think between 5 and 10% of those hits are from Canadians. Most of them are from America. The story is almost identical for all of these thousands of patients. The commonest story is, my doctor told me to stop taking my antidepressant over a few weeks. The effects were so horrendous that I had to go back on them. The doctor told me there shouldn't be a problem with coming off them. It must be my original condition coming back. Diagnosed me with relapse, informed me I should probably be on this drug lifelong. But it felt different to my original condition. I had dizziness, I had brain zaps, I had panic attacks for the first time in my life. So I've lost faith in my doctor, and the advice on this website was much more helpful than my doctor. Coming off much more slowly than my doctor had recommended, at about 10% of the most recent dose per month, so that reductions become smaller and smaller as the total dose lowers. That's the advice that these websites generally give, which can take people months or sometimes years, has made the process much easier to come off. And many of these people are able to come off their medication, although it takes a lot longer than they had anticipated, and it's not necessarily an easy process. We have surveyed about 1,300 of the people on these websites. There's about 180,000 altogether, growing at about 30% every year. What they say about their doctor's advice was they recommended a rate of reduction that was too quick for me, they weren't familiar with withdrawal symptoms, or they suggested that stopping antidepressants would not cause withdrawal symptoms. And just like the guidelines have recommended for many years in America, in England, in Canada, the most common period recommended by doctors was either stopping over 2 weeks or 4 weeks. What patients wanted were the ability to make slower reductions over longer periods of time. And to do that, they wanted to have access to liquid versions of the drug or ways to make up smaller doses so they could make more gradual reductions, and having clinicians that understood what a gradual, flexible, personalized, reducing by these small amounts kind of taper involved. A brief segue into neurobiology here. Apologies. This is a picture of a presynaptic neuron, a serotonergic neuron, a postsynaptic neuron. Serotonin in the presynaptic neuron is released into the synapse and turns red. This is the serotonin transporter, these columns, which suck serotonin back into the presynaptic neuron. And these are postsynaptic serotonin receptors that interact with the synaptic serotonin. When you introduce an antidepressant into the system, you block about 3/4 of the serotonin transporter, and that leads to a buildup of serotonin in the synapse. Because of the law of homeostasis, when it's hot outside, we sweat. When it's cold outside, we shiver. There is an excess of serotonergic activity acting on postsynaptic serotonergic receptors. And so these are downregulated over time. You can see that in PET imaging after just a few weeks of exposure to SSRIs. You can see downregulation of 5-HT2 and 5-HT4 receptors, as well as desensitization of 5-HT1A receptors. Now, when the drug is stopped, the drug is eliminated from the body in a few days or weeks, and the serotonin transporter is allowed to do its thing, which means that synaptic serotonin goes back to normal levels. But the postsynaptic serotonin receptors do not instantly snap back into how they were before the drug was introduced. So there are studies in humans that show changes to the serotonin system can persist for up to 4 years after stopping long-term antidepressant treatment. And what that leads to is a case where you have now normal physiological levels of serotonin in the synapse, but desensitized or reduced postsynaptic serotonin receptors, which overall gives rise to a probable sub or hyposerotonergic state, that is a low serotonin state. And again, that this picture is a summary. There are probably many other neurotransmitters and other processes downstream of these processes that are affected. But what it gives you an idea of is that the changes caused by long-term medication do not instantly reverse on stopping the drug. And the difference between what the brain expects and what the input from the drug is what explains withdrawal effects. This is another very important issue about duration of withdrawal, which is very poorly understood by most clinicians, which is people say the drugs take a few days or weeks to leave your system. So how could you have withdrawal symptoms that persist for longer than that? And that entails a misunderstanding of what causes withdrawal symptoms. So in a systematic review that I'll go through in a second, most studies found that withdrawal effects lasted for longer than just a few weeks. People had months and sometimes years of symptoms. And the reason is because it's the time taken for the brain to readapt to there being less drug that explains how long withdrawal symptoms can last for, not how long it takes the drug to leave the body. Long-term changes in humans that I mentioned is also backed up by findings in animals that show changes to the hormonal system and the serotonergic system that persist for more than a year in human equivalent time after treatment with antidepressants. And I'll give you a quick analogy. to make sense of why these symptoms can last after the drug is out of the system. When you go into a loud concert, your eardrums become less sensitive to sound to protect your eardrums. When you walk out into the quiet street afterwards, sounds sound muffled and quieter for a few minutes afterwards. That's actually a sound withdrawal syndrome. The time taken for the sound to dissipate is a second. When you close the door on the loud concert, the sound goes away. The reason why it takes minutes for sounds to sound normal again is because it takes a few minutes for your eardrum to relax back to its normal levels of sound sensitivity. The same is true for stopping psychiatric drugs, including antidepressants. It's the time taken for the brain to readapt to the drug not being there that explains why these symptoms can be so long lasting for months and years, and not just five half-lives of an antidepressant. So antidepressant withdrawal syndrome are physiological symptoms that occur on stopping or reducing the dose of an antidepressant. They can manifest in either psychological or physical symptoms because these drugs don't just affect the brain, they affect the entire nervous system, the gut, the hormonal system, and every other cell in the body. They occur because changes or adaptation to the brain caused by the drug you take time to resolve, as I've just shown you. Importantly, withdrawal symptoms do not require addiction. Addiction involving compulsion, craving, narrowing repertoire of behaviors. It only requires adaptation to the drug. In pharmacology, adaptation to the long-term use of a psychotropic drug is normally referred to as physical dependence. Unfortunately, this term has become conflated with addiction because of decisions made by the DSM-3 committee, which is not, addiction is not relevant to antidepressants, but physical dependence certainly is. And just to make the point clear, I'm sure that everybody in the audience is physically dependent on caffeine. If you stopped it, you'd get a withdrawal syndrome, not a particularly severe one. But I'm sure that nobody in the audience is injecting caffeine, storing it, stealing from their neighbors to get more of it, because addiction is not generally an issue for most users of caffeine in the same way, but your brain has become adapted to caffeine in the same way as people's brains become adapted to antidepressants. And so physical dependence is the state that predicts withdrawal, and that's certainly relevant for antidepressants. The greater the degree of adaptation to a drug, the greater the withdrawal. So things like higher dose, longer use are more likely to cause withdrawal. The flip side of withdrawal is tolerance, which is seen with antidepressants. In America, they refer to that as poop out, because of course, any drug that causes withdrawal effects also causes tolerance effects. They're the flip side of the same coin. What is some of the phenomenology of the withdrawal syndrome? So people often use the acronym FINISH. That doesn't capture nearly the wide range of symptoms that are included in withdrawal. There are symptoms like dizziness, insomnia, impaired concentration, fatigue, headache, tremor, tachycardia, nightmares. There are affective symptoms like depressed mood, irritability, anxiety, panic attacks. We know that those are symptoms of withdrawal because they have been detected in studies of people who were put on antidepressants for reasons other than mental health conditions. So in studies of people who have stopped antidepressants that were given for pain or the menopause, or even in healthy volunteers, these symptoms are also observed. There are some quite distinctive sensory symptoms, things like electric shock sensations or brain zaps, often in the head, sometimes in the limbs. There are gut symptoms because there's lots of serotonergic neurons in the gut. There's an increase in suicide attempts in the 2 weeks after stopping an antidepressant that's been attributed to withdrawal itself, because it's generally thought to be too soon for a condition to recur in that period. And then the condition that I referred to in the case study, the second one that I showed, akathisia, to me is the most distressing cases that I see of withdrawal from antidepressants. I think if we were talking about headache and dizziness, then I wouldn't be giving this lecture. It's akathisia, which is most recognized as a side effect of long-term antipsychotic use, but can occur in withdrawal from antidepressants and other psychiatric drugs like benzodiazepines. It involves pacing, a sense of terror. People have described this to me like feeling that their nervous system is on fire, and there's a high risk of suicide because it is such an aversive state to be in. I have rarely seen a case diagnosed correctly. It's often misdiagnosed as agitated depression, mania, or in the case of the young woman, as psychosis when clinicians are not familiar with it. Misdiagnosing antidepressant withdrawal as relapse is a very common issue. It's never been studied systematically, but in the 1,400 patients that we surveyed um, from these peer support websites, it was the main reason that they were all there. It's easily understandable why that might happen because withdrawal symptoms can include anxiety, depressed mood, insomnia. Um, uh, it's easy to confuse with relapse of depression or anxiety, especially when guidelines have told clinicians for years that withdrawal or discontinuation, the euphemism from industry, uh, was thought to be only mild and brief. So when people walk into uh, a medical office and they're complaining about severe symptoms that are long lasting, it doesn't match what the textbooks are saying about withdrawal effects, and that's why it's easy to jump to a misdiagnosis. There are a few clues to distinguish withdrawal from relapse. In general, withdrawal is quick in onset, but it can be delayed, as I mentioned, perhaps because of slow dissociation from the central compartment. There are specific symptoms in withdrawal, dizziness, electric shocks, or really any other symptom that's not present in the baseline condition. So the most common withdrawal symptoms from antidepressants are psychological symptoms like anxiety, depressed mood, panic attacks. It's very worthwhile to know what were the symptoms that put the patient on the drug in the first place to compare them to. And patients will often give you the answer themselves when they say, this is nothing like the symptoms I had before I went on the medication. And yet most clinicians will say this is a recurrence of an underlying condition. More helpful in retrospect is that symptoms can resolve on reinstatement of an antidepressant, but the longer you wait, the more it seems to become a condition that doesn't respond to medication. So like the young woman I showed, people who are off their drugs for several months often do not respond as you would predict to reinstatement of the drug. Because there's such a wide variety of symptoms from withdrawal, they can be misdiagnosed as chronic fatigue syndrome, medically unexplained symptoms, neurological disorders, onset of a new psychiatric disorder. There's a very wide plethora of different misdiagnoses that are applied to the presentation. So there's been a single systematic review conducted on how common, severe, and long-lasting withdrawal symptoms are from antidepressants, published now 5 or 6 years ago. It found that about half of patients experience withdrawal symptoms. If you restrict that just to double-blind randomized controlled trials conducted by drug companies, it goes down to about 54%. There are no structured randomized controlled trials looking at severity of withdrawal effects. There are only surveys of self-selected populations, and in these populations, they report that about half of people report that they have severe symptoms. This might be an inflation over the average patient because of the self-selected group. But what is interesting about these surveys is they show a clear biological gradient, which you can see on the graph on the right. The longer you're on a medication, the longer you are to have a withdrawal syndrome. That's the top line. And also, the more likely you are to report that the symptoms are either moderately severe or severe. So you can see that the drug companies focused on people who've been on the drugs for 2 or 3 months. And it is true to say that most people have mild symptoms, although some don't. But when you're talking about people who have been on the drugs for more than 3 years, most of them have withdrawal symptoms, and about half of them report those symptoms as being moderately severe or severe. And as I mentioned before, people can have withdrawal symptoms that last for months or years, not just days or weeks. We haven't published this survey yet. We surveyed people in the public health system in England who were seeking therapy. So these are not a group of self-selected patients. About half of them were on antidepressants. We asked them about their experience stopping, and 40% of them said that they wished to stop antidepressants, had tried 1 or more times, sometimes as many as 8 times, and had been unable to do so because of withdrawal effects. If that population is representative, that extrapolates to about 2 million people in England who are trapped on their antidepressants because the withdrawal symptoms they experience are so aversive when they try to stop. I just want to highlight this protracted antidepressant withdrawal syndrome. So if this was about headache and dizziness for a couple of weeks, as I say, this wouldn't be a big issue. The big issue is that when people come off these drugs, they can have months or years of symptoms that can be neurological, psychological, or somatic. This is a paper published in 2020, looking at a variety of these different patients, showing all the different symptoms of different systems that are affected. And these people universally say these were symptoms they did not have before starting medication. These symptoms were much worse than the symptoms that put them on the medications. And because of the debilitating nature of these symptoms, people have lost jobs, relationships, got into financial difficulties. There's very poor recognition of this by the medical community. I see this as being very similar to long COVID. Long COVID initially was dismissed as how can a virus which lasts for a few days cause trouble for months or years afterwards. In part, there was recognition because there were so many people affected, and especially because there were doctors affected by long COVID, which led to much quicker recognition. From the patients that I've seen, I think the protracted withdrawal syndrome is much more severe than long COVID, although there are some overlapping symptoms. And what happens with these people is because they are turned away by doctors as having psychosomatic conditions or mental health conditions, they end up going to need to find support from outside the medical system, which makes their lives much harder. So, in taking into account the research in this area in the last few years, there has been an update to the NICE guidelines where the Royal College of Psychiatrists in England has put out a position statement and a warning that people should be informed of the potential for severe and long-lasting withdrawal symptoms on stopping antidepressants. They actually went on national TV in 2019 to let the public know about this. In 2021, NICE changed it's updated its guidance to say that withdrawal symptoms can last longer, in some cases several weeks, occasionally several months, and can sometimes be severe, especially when the drug is stopped suddenly. So if that's the issues with coming off these drugs too quickly or inexpertly, then I want to talk a bit about what is the best way to minimize withdrawal symptoms by tapering safely. So why deprescribe antidepressants? Give you a quick overview. Medication may no longer be needed. The stressor may have resolved. As I've said, many people will have a single stressor that puts them in their doctor's office, and relapse is unlikely for most of these people. They may have developed alternative coping skills. Most guidelines recommend that antidepressants are used for 6 to 12 months for a single episode of anxiety or depression. But we know that in the Western world, the average duration of use is moving into years, and some people are on the drugs for decades. There are a number of what are called side effects or adverse effects that may outweigh the benefits. In longer term studies, people on antidepressants, more than half of them will report sexual side effects. More than half will report emotional numbing. That means a restriction in both positive and negative emotions. It's one of the main reasons people come to my clinic that helps people to come off antidepressants, because although that effect may be useful in the short term, in crisis, in the long term, it can affect quality of life, relationships, and a sense of who people are. Fatigue, impaired memory, and concentration are all long-term effects that are found, by the way, in healthy volunteers given antidepressants. Insomnia, and there's also a concern about worsened anxiety or depression in some people that's been called tardive dysphoria. And although in short-term studies there was no evidence of weight gain, in longer-term studies there's clear evidence of weight gain in long-term users of antidepressants. There are no long-term randomized controlled trials comparing placebo to antidepressants, and so the only studies that look at long-term physical health outcomes are observational studies. And in all of these studies, they find that people on antidepressants have an increased risk of strokes, obesity, falls, cardiovascular disease, osteoporosis, and premature mortality. And there's a debate about the degree to which this is attributed to the underlying disorder or antidepressants themselves, with more or less plausibility for some of the specific symptoms, health consequences. Or patients may simply wish to stop. So in England, that is highlighted as a very legitimate reason for people to be supported to do so. A woman may wish to become pregnant. The data says that there's an increase in teratogenicity risk that's about 2.5 to 3-fold for most common antidepressants, although it's from a low base rate. And for older patients, reducing pill burden or interactions with other medications may be another reason. I want to put in one point about the evidence for long-term use of antidepressants. So in the NICE guidelines, in the CANMAT guidelines, in most guidelines, they recommend long-term treatment with antidepressants to prevent relapse for people that are at higher risk. And I'm not sure that everyone understands that these guidelines are based not on continuation studies, but on discontinuation studies. In particular, a very influential meta-analysis of these studies by Geddes in The Lancet in 2003. And what these studies involve are people who are remitted on antidepressants, they've responded, and they are randomized into either stopping the medication or continuing the medication. They are then monitored for the next 6 to 12 months, looking for relapse of depression using scales like the Hamilton Depression Scale or the MADRS. And if you put together the 31 or so studies in this meta-analysis, what you find is that the people who stop antidepressants, about 40% relapse, and in the group that continue on antidepressants, a bit less than 20% relapse. And the difference between these two rates is why guidelines recommend people to stay on antidepressants long-term to reduce their rate of relapse, saying it reduces your risk, your relative risk, by about half. There are some limitations to this literature. Number one, it's already a highly selected group of people that have responded to antidepressants, not the entire group of people that are exposed to antidepressants. But even more importantly is the way that the drugs are stopped in these trials. So the most common way they're stopped is over 1 day, and the average period is 5 days. This will produce withdrawal effects in many patients. Perhaps up to half, perhaps up to a quarter will have severe effects. We know that withdrawal effects will include symptoms of anxiety, sleep changes, appetite changes, mood changes, all of which overlap with items on the depression rating scales. And withdrawal symptoms are not measured in any of these studies. They're not distinguished, which means that a proportion of the people who are said to have relapsed in this group will actually have had withdrawal effects misclassified as relapse, which means that the difference between these two groups will not be as large as is as reported. And people that have tried to work out what degree of this can be explained by withdrawal effects have suggested that it may all be explained by withdrawal effects. Because, for example, if 1 in 4 people have severe withdrawal effects, that explains the entire difference here of 23%. And so it's not clear if antidepressants prevent relapse or whether antidepressants prevent withdrawal effects from antidepressants, because to make it very simple and slightly glib, if people who were smokers were divided into stopping or continuing and anxiety scores measured, we would conclude that people need to continue smoking to prevent anxiety if we don't take into account withdrawal effects. So that may be what has happened with antidepressants. So why taper these drugs? So if you decided to stop the drugs in a specific patient, why would you taper them? I tried to make it clear here in a bit of a cartoon. You start the drug levels go up, blue dotted line. The black line is the homeostatic level of the brain, what it gets used to. So it gets used to higher levels. When people are on stable doses, in general, the system is stable in a new homeostatic equilibrium. When the drug is stopped, it's eliminated from the body by the liver and kidneys in a few days or weeks. And as I showed earlier on, the brain lags behind in accommodating, in changing its homeostatic set point to what the drug is actually supplying. And the difference between what the brain expects and what the drug is inputting is the shaded area under the graph, which is what withdrawal symptoms are caused by, a mismatch between what the brain expects and what the drug is supplying. And a way to minimize that is to reduce by small amounts, do it in steps, that's tapering. And in that way, the difference between what the brain expects and what the drug is providing is smaller. There's still withdrawal effects, but the area under the curve is minimized. An analogy might be, this is like jumping off the top of a building in one go. It's going to cause the biggest disruption. This is like coming down story by story. And to make it even easier, if you come down step by step, that will minimize the withdrawal symptoms even more carefully. And so minimize the disruption to people's lives. The Royal College of Psychiatrists put out guidance on stopping antidepressants now a few years ago, and it recommends some broad principles for coming off these drugs. It says that for people that have been on antidepressants for more than a few weeks, they should taper off over months or longer. They suggest going down to very small doses, less than 1 milligram before stopping for people that have trouble coming off. And they recommend going down in smaller and smaller size reductions, and that the rate should be adjusted or titrated to the individual's ability to tolerate the process. I'll just quickly go through where some of those ideas came from. So we published a paper a few years ago now in the Lancet Psychiatry that's focused on how do these drugs affect the brain in what pattern. And this is PET imaging of citalopram versus, it says effect on the brain here. This is actually inhibition of the serotonin transporter. And the key point is it's not a straight line, it's a hyperbola. So that, for example, 20 milligrams of a drug has much more than half the effect of 40 milligrams in terms of effect on the brain. This relationship arises because of the law of mass action. When there's not much drug in the brain, all the receptors for the drug are unsaturated, open for business. And so every milligram of drug has a very large effect on the brain, a little bit like the game of musical chairs at the beginning of the game. All the chairs are available. As there's more and more drug in the system, more of the receptors are saturated. And so every extra milligram of drug has less and less incremental effect. And so you get this curve. I say that because this is not just true for citalopram, it's actually true for all antidepressants, for all targets, all receptor targets, whether that's noradrenaline transporter or other receptors. And it's actually true for all psychiatric drugs in general because they all conform to the law of mass action. This understanding, and I should say also that there are similar relationships for symptoms, relief caused by the drugs, for side effects. If you put a micropipette in a rat's brain, you'll see the same relationship between dose of antidepressant and serotonin levels. So this is not just a disembodied relationship in PET imaging. It's true of every level of biological systems in response to antidepressants. It allows us to understand what happens when we take the kind of advice in the old NICE guidelines or the current CAN-MAT guidelines, which recommend going down essentially in a linear way. So to go down from, say, 20 milligrams of citalopram, 15, 10, 5, 0, it sounds intuitively very appealing. You can do it quite easily with dividing up tablets or give it every second day. What happens is going down from 20 to 15 causes a very small change in effect on receptor occupancy, 15 to 10 slightly larger again, 10 to 5 larger again, and 5 to 0 is about, it causes an effect that's about 20 times the effect of going down from 20 to 15. And that's exactly what patients report, that the first few milligrams of a drug are the easiest to reduce and the last few milligrams are the hardest. And when clinicians don't understand this relationship, they often conclude that people either need the last few milligrams or their symptoms suggest relapse, and they're often put back on medication. But if we understand this relationship, we can work out a more pharmacologically rational way of stopping medications, which involves, I've drawn on 4 lines that are horizontal, separated by 20 percentage points of occupancy. And what that requires is this rather more peculiar pattern of reductions that gets smaller and smaller, the size reductions, down to extremely small doses before stopping, so that this reduction from this final dose to 0 doesn't cause a greater change in effect on the brain as the previous dose reductions did. And so you can see that for citalopram, doing it in 4 steps will involve going down to a dose that's less than a milligram, and these doses will get smaller and smaller in their reductions. And because this shape is a hyperbola, this has been called hyperbolic tapering. An approximation of hyperbolic tapering is what's called proportional tapering. So for example, reducing by half each time, 20, 10, 5, 2.5, 1.25, 0.6, approximately produces even changes in effect on the brain, not quite, but not too far off. And even this sort of reduction might be too fast for some people. These jumps may be too big. And so people insert extra steps in between this, and that will produce reductions by, say, 25% each month. And some people will need 10% dose reductions per month. And so you can see we've actually ended up exactly where these online websites recommend for people to go. So they have, I think it's quite extraordinary, through trial and error, they have found a pattern of reduction that exactly matches the receptor occupancy of these drugs. And I suspect that's no coincidence. And lots of people find that they can't come off in this kind of way, but they can come off when they do this sort of reduction. As I said, it's true for all antidepressants. It's not just for citalopram. The shape exists for all these drugs. To return to the guidance from the Royal College of Psychiatrists, because it's hard to tell by looking at somebody how much difficulty they're going to have coming off their antidepressant, there's a few, I can show you quickly, there's a few guides. There's a little bit of trial and error, and people should have the rate adjusted to what they can tolerate. So if symptoms become too severe, then the reduction should be halted or the dose increased until symptoms resolve, and then the reduction should proceed at a slower pace. And the Royal College of Psychiatrists now gives the same advice as these peer support sites, that some people may need to go as slowly as 10% of their most recent reductions per month, which means reductions get smaller and smaller. They give a couple of examples. This is almost identical to the example I showed you before, halving doses of citalopram all the way down to 0.6 milligrams. This I would think of this as a reduction that's quite rapid, maybe for people who'd only been on the drug a few months. They also give an example of coming off paroxetine, which is a particularly hard drug to come off, that involves going down by 10% of the most recent dose every 2 to 4 weeks. So starting off by going down at 4 milligrams when you're at 40 milligrams, and then going down by 2 milligrams when you're down to 20. And in fact, there's 30 further steps here. And this process can take people 2 or 3 years. And in my clinic, I have certainly seen people that have found coming off paroxetine to be so unpleasant, it can take them 2+ years getting down to this very small final dose. And using liquids or another way of getting these smaller doses is important. The NICE guidelines were updated a couple of years ago, and they reflect the Royal College guidelines and what I've shown you previously. They recommend reducing by a proportion of the previous dose. They're using that simpler way of describing hyperbolic tapering. For example, 50% of the previous dose. They also suggest it may need to be smaller for some people, 25%. They recommend using liquid preparations when these doses cannot be achieved using tablets or capsules, and they highlight that the rate of reduction should be agreed on with the patient, led by their withdrawal symptoms, and they try to set expectations that reductions can take weeks or months, and it can, for some people, take years. The first questions I get is, how do you make up these doses? So in the UK, we're in a bit of a different situation to in Canada because most antidepressants come as liquids. I think in Canada, maybe only fluoxetine does. There are other options like compounded medications. Another trick that doctors try to use is to skip doses. This generally works out very badly because, except for fluoxetine, the half-life of most antidepressants is about 24 hours. And so when dosing happens every second day, plasma levels will drop to about a quarter of their peak levels after 2 days. And that can lead to wildly changing levels that can cause severe withdrawal symptoms in some patients. And so it's better to give the same small dose every day rather than give a larger dose every second day, the exception being for fluoxetine. And so this little cartoon in the top is making a very important point, that the smallest tablet or capsule available for all antidepressants is generally too large to allow people to taper off slowly. Even halving the dose or quartering the dose is also often too large. So for example, for citalopram, the smallest tablet is often 20 milligrams. And so even halving it or quartering it still doesn't put you close enough to the bottom of this curve to allow people to come off. And that's why for most long-term users that have had trouble, they will need something other than widely available tablets. I'll skip through these things quickly. This has become a priority in the NHS in England. They have asked for clinics to be set up to help people stop these drugs. I run the first such clinic. Reducing inappropriate use of antidepressants has become a national priority. And they also want to set up clinics to help people who have protracted and severe problems with withdrawal, a bit like a long COVID clinic. One of the issues that comes up is the NICE guidelines are very broad brushstrokes. And we wrote this textbook, the Modes of Deprescribing Guidelines, that covers how to stop antidepressants, benzodiazepines, gabapentinoids, and Z drugs, that gives specific guidance for every licensed medication in terms of both slow, moderate, and fast regimes for each drug, how to adjust them to the individual, and how to walk people from the process of deciding to come off to coming off safely. I'll just do this very quickly. There are risk factors that are recognized from the literature that can help you decide who is a high risk, moderate risk, or low risk patient to work out what speed they could come off at. These are some rules of thumb. These 10% dose reductions are slow for long-term users. Other people can use 25 or 50%. The big trick being the reduction, that the rate of reduction has to reduce as the total dose reduces. That's how the proportion, that's how the proportion aspect comes into it. We give examples of reduction regimes for different drugs and what formulations to use, including both licensed and unlicensed formulations. There's a lot of guidance in England about how to use unlicensed versions of drugs, people that can't swallow, for example, crushing up tablets that can be used for people who can't get access to smaller doses. There are some slower versions, and there are ways. This is the way that we use in our clinic and in the textbook on what rate works for people. So whether symptoms are tolerable out of 10, whether they become quite unpleasant, people need to slow down, or very unpleasant, people need to go up to a higher dose. We talk about how to monitor patients carefully. I'll skip through this. I'll just say everything that I've said for antidepressants is true for benzodiazepines. The same graphs apply. Going down from 100 milligrams to 75 milligrams causes less of a change in the brain as going down from 1 to 0. We give some examples of that. And the same is true for coming off gabapentin, so like pregabalin and gabapentin, exactly the same curves pertain, but it's much harder at the end. It's also true for antipsychotics, mood stabilizers, stimulants, opioids, and even physical health meds like beta blockers and PPIs. And that's because the law of mass action is a universal pharmacological law. And I'll leave that. So there's some time for questions.
Thank you, Mark. That was so very interesting. I'm going to get right to the questions. I apologize because we won't get to all of them, but I'll start from the beginning. So I know you went over this, but if you can provide a brief overview again, that would be helpful. Why do some experience an adverse reaction when reinstating the drug while in withdrawal?
I don't know. There has been no research on this. There are 1,000 studies on starting antidepressants. There's only a dozen on stopping them. There's no research in why some people react well to reinstatement and some people don't. The ideas out there are that people, if the issue is withdrawal per se, then you're missing the drug, giving the drug back improves things. If the issue is an injury sustained to the brain because of changes in the chemistry, then reinstatement won't work. I don't know what the nature of that injury is or what would cause it. There needs to be a lot more research to make sense of it.
Okay, and the downregulation of receptors and what that means in terms of how the body or the brain responds to reintroduction, may that play a part in it?
Possibly, again, there's only a handful of studies looking at this downregulation at the changes. It may well be that the configuration of the brain has changed.
Sure.
Yes, a bit unknown at the moment.
Okay, thanks. The next question, what are the considerations for antidepressant withdrawal syndrome in the context of cross tapers?
So I say a couple of things. One, every study on switching antidepressants has been negative. So there's 8 randomized controlled trials summarized in a meta-analysis by Bashaw that finds that switching to another antidepressant does not improve outcomes, doesn't improve symptom scores. So this idea that you got to keep you got to keep trying antidepressants to find the right one is not based on evidence. If people are switching because of side effects, that might make some sense. The more different the affinities of the drugs switching between, the more likely withdrawal effects are to occur. And so some of this hyperbolic tapering might be taken into account if you're changing drugs that are very dissimilar. The SSRIs as a class are more dissimilar than you would think. So people can have trouble going from sertraline to fluoxetine, although they look to be very similar. So I would advise caution and going more slowly than people generally do.
Thank you, Mark. One of the things I found interesting that you talk about is the distinction between symptoms that occur during withdrawal that do not resemble anything like why they sought out an antidepressant in the first place. Just wondering on your thoughts or your experience, would it be useful when people are starting depressants to very clearly document what the symptoms were in an effort to reflect back on that later and say, this is what we were talking about?
Absolutely. Yes.
Okay. There is a comment here, and I just want to bring it up to make sure that the person feels heard about conflating addiction with criminality. And
I apologize. I was sorry. Maybe
No,
a bit. I read that. I'm sorry. You're right.
Thank you for addressing that. So if people have been on concurrent antidepressants for 20 plus years, is there hope for being able to come off these, or are they essentially stuck due to withdrawal?
So it's a good question. We've just done in the survey that I mentioned about people who can't stop antidepressants. The longer you're on an antidepressant, the harder it is to stop, the more likely you are to have difficulty stopping because your brain is adapted to the drugs more. I've seen people who have been on antidepressants for 20 years that are able to come off. Often they need to do it very slowly to avoid severe withdrawal effects. But you're right, there's a group of people who are stuck on these drugs because they've been on them for so long. I think that needs to be part of the informed consent when people start medications, that they need to be told that it may take them years to come off these drugs.
Mm.
The withdrawal effects may be so severe that they're debilitated by it, or they may not be able to stop the drugs. That is part of informed consent now in England. That's come from the Royal College of Psychiatrists and also from NICE, that
Mm.
people need to be warned about these effects, and I think that's important.
When you do informed consent in your practice, I'm just curious how you describe the potential for akathisia if they were to come off later on.
Right. I'm not sure I've said it specifically, but I probably should. There's an unknown proportion of people who develop akathisia when coming off these drugs.
Mhm.
To me, as I said, it is terrifying. I've seen reports about there being a 30% suicide rate in akathisia. I don't know what the denominator is in that. I've
Mhm.
never seen people that agitated in my life. It's unpleasant just to talk to them, let alone be them. They're pacing, they're beside themselves, they get no rest. When people are coming off antidepressants, I say this is a really strong reason to come off very slowly, because people that come off quickly can really develop these issues. But I tell people there could be major risks to coming off these drugs, and they could be long lasting.
And just to remind people about what you said, that it's often misdiagnosed as an anxiety-related new condition potentially.
Yeah.
Moving on to the next question, what about titration off on different antidepressants for pregnancy planning?
So I guess this comes back to the issue about, so of course, if you're coming off an antidepressant, you'll be at risk of withdrawal effects. I think that it's not my area, but I think that people think that specific antidepressants are at lower risk than other antidepressants. But my understanding is that as a class, they're fairly similar. You'd have to think carefully about what the benefits of being on the drugs are. As I sort of pointed out, the relapse prevention properties of antidepressants are probably greatly overstated by the way the studies are done. Because of tolerance effects, these drugs can wear off. So I think there's going to be very careful consideration about the risks of being on these drugs during pregnancy and any benefits to the mother.
Okay. There was an early question about MAOI inhibitors, and based on your comments about gabapentinoids and benzodiazepines and the curves being similar, would that be fair to say that it's the same?
It's the same, exactly. So it's the same hyperbolic relationship, the same kind of approach. Sometimes MAOIs, because they do irreversible inhibition, there's a little bit of self-tapering, but essentially the principles are the same.
Okay, I'm going to go to one more comment and then we'll wrap up. So the last comment is, you might consider adding another reason to deprescribe, which is dysphagia. It's not uncommon with longer mediastinal problems. So could you respond to that?
I had terrible dysphagia on antidepressants. I used to choke on my food all the time, which has gone away and coming off it. So I'm sold.
Okay. So Dr. Horowitz, thank you so much for an excellent presentation.